Hello everyone. Today we'll be looking at the appearance of the oral cavity. That's the topic of today's session. And I'm your presenter, Dr. Syed Jafar Abbas Zaidi. And we'll be looking at the differences of the oral cavity in health and disease. Now, we'll start off with my introduction. So I'm an assistant professor in the Department of Oral Biology at Daw Dental College, which is a constituent institution of the Daw University of Health Sciences. So, without further delay, we'll start off with the learning objectives of today's session. So, the learning objectives are that by the end of this session, students will be able to use correct anatomical and dental terminologies to describe the features which are present in the oral cavity that are besides the teeth. And we'll be looking at the functional significance of the lip posture in making an anterior oral seal, and we'll be appreciating the normal and abnormal lip postures. Finally, we'll be looking at the different clinical relevances of the mouth in terms of normal variation and disorders that might be common or benign disorders, and how to differentiate between a benign or a possibly life-threatening disorder. So we'll be looking at all of these aspects in this interactive session. So this is how uh, and lip look like, and we'll be looking at the different terminologies. So as you can see here, all this area which is encircled by the lips is known as the vermilion zone. The area where uh, the lips are found is known as the vermilion border. Now I'm encircling the vermilion border, and whatever is inside this vermilion border is known as the vermilion zone. And this is a feature characteristic of humans, which is not present in any other uh, mammals. Secondly, uh, in the upper lip, there is a protruded portion which is known as the tubercle. And just beneath the tubercle, there's a pinpoint depression in the lower lip. Now, there are certain grooves present near the lips on the face, and we will be looking at the terminologies of it. Now, we have a nasolabial groove here and on the right side here. Now, these nasolabial grooves are not so prominent in the young, but with age, they become much more exaggerated and much more prominent. Then we have the labiomental uh, groove. This is the labiomental groove, and we have the labial commissure. By labial commissure, we mean the corner of the mouth. So these corners of the mouth are known as the labial commissures. Now, the area just above the upper lip and below the nose is known as the philtrum. So, and then we have the labio-marginal sulci. This area here is known as the labio-marginal sulci. And this is how the oral cavity looks like. In the oral cavity, we have the vestibule, which is the opening of the oral cavity, and then we have the oral cavity proper. The oral cavity proper is actually has boundaries of the teeth uh, when it is closed, and when it is open, then we have the oral vestibule or the vestibular fornix, which has boundaries of lips and the cheeks in front and the teeth at the back. Now, this is another picture of how uh, the teeth and the structures of the face they look like. Now we have the commissure, which is the we have the commissure here, which are the corner of the lips or the corner of the mouth. Then we have the philtrum here, the nasolabial grooves, the labiomental grooves, and then this is the vestibule or the orifice. Now there's another terminology which is used is known as the mucocutaneous junction. The junction where the lip meets the skin of the face is known as the mucocutaneous junction. So this is just another picture to get a better understanding of all of these structures and their respective terminologies. Now we will look at the anterior oral seal. And anterior oral seal are the competent or incompetent lips are actually uh, followed by the teeth. Now, if you just look at this child at rest has lips which are apart from each other. Now, such lips which do not touch each other during the resting stage are known as incompetent lips. Now, this can happen due to two reasons. First of all, if the teeth are protruding, as in this young child, the teeth are actually, because of the teeth in between the lips cannot close properly, they cannot approximate each other. And due to this condition, what happens is the lips become incompetent and there's a gap in between the teeth and the lips. And since this gap exists during mastication and during chewing and during eating and drinking, an anterior oral seal cannot be formed effectively. For this purpose, what happens is a tongue is usually used to close the gap in between the lips and the teeth. And this use of tongue to close the gap is known as tongue thrust. Now, another reason why the lips might not approximate each other or might not touch each other is due to mouth breathing. So, mouth breathers, uh, they although they have competent lips and they can close their lips, but during the resting stage, what happens is the lips are apart from each other. Now, in these mouth breathers, what happens is since they're accustomed, they're used to breathe, they're used to breathing from the mouth, they cannot close their lips during resting stage. But in mouth breathers, what happens is anterior oral seal is formed by the lips, and the lips are considered to be competent. So now just a brief glance at the lip. Now, the lip has two parts. If you look at from above, now if you protrude the lip, if you hold the lip, there is the vermilion border, and the vermilion border has actually two parts, the one which is on the outer part and then which is dry and it doesn't have any salivary glands, and then there is the inner part which has mucous membrane in it and it has multiple labial salivary glands, and the area which is demarcated by is known as the wet or the wet dry line. So the area uh, which demarcates the outer lip, which is dry, from the inner lip, which is wet, there is a wet dry line. So this is the wet dry line here, and this actually shows us the demarcation or the boundary between the wet part of the inner lip and the dry part of the outer lip. And that is why we need to frequently, when there is dry weather or there is cold weather, we need to hydrate the lips, and this is done by the tongue. So now we look at some parts of the oral cavity. Now, when the teeth are in occlusion, when they are closed, this whole area is known as the vestibular fornix. The vestibular fornix has the cheeks on the sides and the lips in front, and it has the teeth on its back. Once we the occlusion, once we ask the individual to open his or her mouth, whatever is inside the teeth is known as the oral cavity proper. So this is the vestibular fornix, and then we have the lip, which is attached to the gums through the labial frenum. So this is the labial frenum, and then we have the buccal frena as well, through which the cheeks are attached to the gums. So what happens in certain circumstances and certain individuals, although in great minority, this labial frenum is attached to is far below the alveolar crest and it lies in between the teeth, and due to the lower attachment of the labial frenum, a gap then forms in between the front maxillary teeth, and this gap is known as diastema of the teeth. And the usual remedy or the usual treatment is that this labial frenum is surgically incised, and then it is attached at a higher area, and then these teeth are orthodontically, then they're made to approximate each other. So this is another picture of the vermilion zone and the vermilion border for clarification purposes. And this is also how the alveolar mucosa is differentiated from the attached gingiva. If we just look at the alveolar mucosa, it is of reddish color, while the attached gingiva or the labial maxillary gingiva, it is pale in color. So this because of two reasons. First of all, the alveolar mucosa has an underlying submucosa, and it is unkeratinized, while the labial maxillary gingiva uh, it is keratinized, and it doesn't have an underlying submucosa. It is directly attached to the periosteum. That is why it is known as the mucoperiosteum. Okay, now just a brief anatomy uh, of the oral cavity. Now this is where this shows the tongue, and uh, these are the posterior mandibular teeth. Now if you go posteriorly, we have a space here, and this area of soft tissue is known as the trichomandibular raphe, and this is of clinical significance. Why? Because anterior two-third of it is used as a landmark for the approximation of a needle during a inferior alveolar nerve block or mandibular block when we are trying to anesthetize or numb the mandibular teeth. So trigeminal raphe is an important landmark which is used for giving or administering an anesthesia to achieve an inferior alveolar or mandibular nerve block. So another importance of the buccal frenulum or the buccal freni, frenulum is singular and freni is plural, is that uh, just where the crown of the second maxillary molar is, there is a papilla and orifice of the parotid duct. Now, parotid duct is a major salivary gland, and it is one of the largest salivary glands that have ducts with their excretory ducts in the oral cavity, from which the saliva is produced or extruded. So we have three major salivary glands. The first major salivary gland is the parotid duct. The second is the submandibular duct and gland, and the third is the submandibular sublingual salivary gland. So we have a parotid gland, we have a submandibular, and then we have a sublingual gland as the major salivary gland. Now, a little bit of clinical significance. This area of whitish line is sometimes found in individuals on the inner sides of the cheek, and this is the area where what happens is the inner side of the cheek is traumatized intermittently during eating, and due to its constant trauma or constant light intermittent trauma leads to hyperkeratinization of the buccal mucosa. So buccal mucosa becomes a little bit more keratinized than usual, and we can see a whitish line that appears here. Now, this whitish line is known as linea alba, and it is considered to be a normal variation of the buccal mucosa. So, just this picture is shown here just to appreciate that besides the three major salivary glands, we have numerous salivary glands that are shown by the yellow color here. Now, these salivary glands are around 700 to 1000 in number, and they are found all over the oral cavity. They are found in the palate, they are found in the lips, they are found in the gums. Now, a little bit of attached gingiva, and we're looking at photodiasis spots as well. So this is a picture of the attached gingiva. So the attached gingiva has certain parts. The attached gingiva, as you can see, has a stippled appearance. Stippled appearance means it is of paler color as compared to the alveolar mucosa, and the reason being that there is no submucosa in the attached gingiva. The attached gingiva also, if you just look at this, it has a scalloped appearance, and it follows the neck of the teeth, and it has a free gingiva. The free gingiva is an area where the gum meets the teeth, and uh, there's a gingival crevice there in which there's a gingival clavicular fluid, and the free gingiva usually has a depth of up to 3 to 4 millimeters. So now we look at the palate. So the palate usually has an incisive papilla here just behind the maxillary uh, anterior teeth, and then the incisive papilla is followed with a uh, uh, by the palatine rugae. Now palatine rugae are actually protuberances that are found on the palate in the anterior part. And if you just look at, there's a midline, there's a line, and this is known as the palatine raphe, and it actually shows that the right part of the palate has formed by fusion with the left part of the palate. And we can see teeth here. The most posterior part of the hard palate is known as the soft palate, which doesn't have any bony underlying bone. And then the soft palate is continuous. It goes. The most posterior part is known as the uvula. Okay, now we'll look at the of how our mouth communicates with the pharynx, with the airway. So we have a soft palate here, and just at the where the soft palate ends, there's a palatoglossal arch. Now, so this is the palatoglossal arch. So the palatoglossal arch is anterior arch, and there's a uh, arch which is posterior to it, and it is known as the, here it can be shown here, it is known as the pharyngeal arch. So we have a palatoglossal arch, and then we have a palatopharyngeal arch, which is much more posterior, and the tonsil, which is known as the palatine tonsil, is usually present in between the palatoglossal arch and the palatopharyngeal arch. So we'll now just briefly look at the structure of the tongue. So this is the anterior part, and the superior part of the tongue is known as the dorsum, or the dorsal surface of the tongue. So it has two parts. The first part is known as the palatal part, which is the anterior two-third, and the posterior two-third is known as the pharyngeal part. And what actually demarcates the anterior and the posterior part is the sulcus terminalis, which is a V-shaped structure. And just anterior to the sulcus terminalis, there are around 7 to 10 protuberances, which are known as circumvallate papillae. Now, these circumvallate papillae actually has salivary glands within them, and these salivary glands are known as glands of von Ebner, which are serous in nature, and they secrete serous saliva. Now, this is the underside of the tongue, and this is known as the ventral surface of the tongue. What you can actually see here is that the lingual veins are quite prominent here, and these lingual veins, these deep lingual veins, can be seen because the mucosa is very thin here, and because it is very thin, the veins are actually can be seen, and it is unkeratinized. So we have a lingual frenum through which the tongue is attached to the floor of the mouth. So we have the floor of the mouth, and just in the middle of it, there's a lingual frenum. And just anterior to the lingual frenum, we have a protuberance, and this protuberance is known as the is known as the sublingual papilla. And just on the right and left side, we have a sublingual fold. So these are sublingual folds in which the duct of the sublingual gland its duct is there, which excretes the sublingual gland saliva, while the sublingual papilla is the area where the sublingual duct comes out. Besides, there are fimbriated folds on the inner side of the tongue. So these are the imbriated folds. Now there is a clinical relevance of the inner side of the tongue, since it doesn't have any keratinization, and its layer is not so thick, and the mucous membrane is quite thin over here. It is so thin that you can actually see veins through it. Any Another important function of the inner side of the tongue is absorption. So that is why medicines such as anti-inguinal medications are can be given here, and not only just painkillers such as Panadol or analgesics can also be placed directly into the lower side of the tongue, and they can be absorbed into the bloodstream. Okay, so the floor of the mouth. What is the significance of the floor of the mouth? We have already just discussed here. And the floor of the mouth is actually formed by the mylohyoid muscle. So we have a mylohyoid muscle. There's a right and left mylohyoid muscle, which together they form the diaphragm for the mouth. And they actually delineate the floor of the mouth from the suprahyoid region. So the digastric muscle is below that. The suprahyoid and the infrahyoid muscles are all below it. And this is where the floor of the mouth actually is formed by the mylohyoid muscles. So a little bit more of clinical relevance is the presence of black hairy tongue. So in the tongue we have papillae. So there are three different types of papillae. We have the filiform papillae, which are the most numerous, but they are the smallest in size. Then we have the little bit bigger. Than them we have the fungiform papillae, which are less numerous in number, and they are reddish in color, followed by the sides of the tongue. They are foliate papillae, and these foliate papillae are slit-like. They have a slit-like appearances, and then just anterior to the sulcus terminalis, we have the largest salivary, the largest papillae, and these are known as the circumvallate papillae. So in certain conditions, uh, in certain individuals, the filiform papillae become elongated, and bacterial deposits as well as food debris they accumulate on these filiform papillae, and this condition is known as the black hairy tongue, as you can see in this individual. But there are no hair follicles on this tongue. The only reason why it is given the name of the black hairy tongue, because it has resemblance to black hairs, but there are no hairs here. These are just filiform papillae. Another clinical relevance is the presence of the Fordyce spots. Here on the lips of this individual, we can see yellowish appearances, and these yellowish Fordyce spots are actually ectopic sebaceous glands. The sebaceous glands are usually found along with sweat glands just besides the hair follicles in the skin, and they secrete sebum, which is a greasy substance. Now, in certain individuals, these sebaceous glands can be found not only in the inner side of the lips, but on the sides of the cheeks, as we can see in this picture. We can see the linea alba here, which represents an hyperkeratinized area where it is in between where the occlusion takes place. Then we have the Fordyce spots here, which is on the inner side of the cheek. And these Fordyce spots sometimes are, they usually appear during the puberty stage. And there's nothing wrong with them. This is just normal sebaceous glands, and there's nothing to worry about. Okay, so this is just another picture showing us the alveolar mucosa and the significance of the attached gingiva. So we have already discussed where this midline diastema takes place because of the lower attachment of the labial frenum. Now this picture actually shows us the structure of the tongue and the clinical significance of the different taste buds that are present. So the anterior tooth of the tongue has different innervation as compared to the posterior two-third of the tongue. And just to make interesting, we have this is the tongue of a tiger, and as you can see here, it has very elongated filiform papillae. The reason why filiform papillae are elongated in a tiger's tongue is that uh, the tiger usually drinks not only strips the skin of its prey, but it also absorbs the blood of its prey through this filiform papillae. So filiform papillae has dual function in tigers, and not only does it has a stripping function, it strips off the skin as it is very abrasive, and it also acts as absorbing as an absorbent agent for blood. So in a tiger, what happens is these elongated papillae have dual functions. These long filiform papillae are used for absorption of blood of its prey and for stripping of skin from its prey. Now, this is how circumpallate papillae they actually look like on the tongue. So these are just protuberances, or it's an area on the posterior side of the tongue where you can actually see uh, these these circumpallate papillae with the von Ebner's glands. Okay, in certain individuals, what happens is that in this is a mandibular teeth, and we have little outgrowths of bone, and these outgrowths of bone are known as torus or tori if they are bilateral, and we can see mandibular tori on the mandibular teeth. Now these are just bony outgrowths and bony exostosis. There's nothing wrong with them. The only problem is that if the teeth are not present and we need to fabricate dentures, then we need to surgically remove these tori. Okay, on this right in this picture, we can see smoker's keratosis or smoker's palate. So what happens is in smokers, there is excessive hyperkeratinization because of the presence of tobacco, and this hyperkeratinization showed in the whitish appearance, and the whitish appearance uh, has pinpoint reddish spots, and these pinpoint reddish spots are actually the excretory ducts of the minor salivary glands. So finally, a little bit of clinical relevance. In certain individuals, there's melanin formation, and this melanin formation is shown by the dark attached gingiva, and this is considered to be normal because melanin production uh, is seen in dark-skinned individuals. And here, this is the side of the tongue showing the foliate papillae, which have a slit-like appearances. And on the extreme right, what we see here, there is increased pigmentation, and there is striae-like appearance, which is seen in lichen planus. And lichen planus is a condition that affects the mucous membrane, and it has alternating patches, white patches followed by unkeratinized ulcerated area as well. This is an example of a palatal palatal torus. It is a large torus here, which is in bony overgrowth, and then we have a mandibular torus. Here we have another small torus palatinus. So, lastly, we need to appreciate the normal oral cavity with all its landmarks so that we can see what kind of pathology is present. And another important point to note is that any area which is normally unkeratinized in the oral cavity, if it becomes keratinized due to trauma or any other insult, then it is of concern as it can lead to a precancerous condition, and it should be regarded as suspicious whenever we see keratinization in an area where normally it is unkeratinized. For instance, the floor of the mouth, the sides of the tongue, and the inner sides of the lips and cheeks. Then they should normally be unkeratinized. But if we see any keratinization, and this keratinization is usually seen as whitish areas, so any whitish areas which cannot be scraped off, if they are present on the inner side of the cheek, and the inner side of the lips, and the underside of the tongue, then they should be regarded as suspicious areas, and they should be referred to an oral medicine or an oral surgeon. So thank you for listening. So if you have any queries, you are more than welcome to email me, and I'll be more than glad to answer any of your queries. Thank you.